years, and I struggled a lot. And I struggled with that feeling. I hear people say things a lot about certain types of cancer, particularly Hodgkin's, like, this is the good one. It's the cancer lottery.
Right.
And it certainly didn't feel that way. It felt really hard in my life. So anyway, I could go on and on, but that's sort of the beginning.
I mean, just the beginning, but thank you for sharing all that. And I hate when I hear that, you know, whatever cancer it is, whenever people say, oh, and then I was told, that's all right, you got the good one. And it's just like the worst. So thank you, Sam. Chelsea, how about you? What were the first symptoms for you or the red flags?
Yeah, so I was first diagnosed with Hodgkin's in 2018 when I was 28, and I was working a lot of hours. So I was very tired, just like Sam mentioned, but I didn't think much of it. I had weight loss I was trying, I was on Weight Watchers, but it never worked before, and then just suddenly started working. I had shortness of breath, and then at one point I almost crashed my car because I had a vertigo episode. So I ended up going to the doctor, and they told me it was just stress. And the only reason I got diagnosed with Hodgkin's was I eventually had a lump come up on the base of my neck on the left side. And I went to the urgent care. They told me that I just needed antibiotics, but there was something in their eyes that told me that wasn't all I needed. So eventually my family forced me to go to the ER, and we got a full biopsy done. I was in the hospital for the first time. And then, long story short, I had stage 2 Hodgkin's, and I also did ABVD. And about halfway through, we had to drop Bleo because I had toxicity. So I know we're going to talk about that a little bit more later, but yeah, and then I was re-diagnosed with Hodgkin's in 2019 as well.
Yeah, and we'll dive into, like you said, that experience with bleomycin, and also really you, Chelsea, personifying self-advocacy too, you know, just in terms of this doesn't feel right, I'm going to do my own research. And I think that's a really great message. So thank you for sharing, both of you. So Dr. Matazar, bringing you back in to highlight this discussion tonight, kind of setting the stage on a higher level. The treatment landscape in Hodgkin lymphoma has been changing quickly, to Sam's point earlier. Can you share more, again, high level, about the evolution that's been going on?
Totally. First, I'm just going to echo what you said, like hearing, Chelsea, how you knew better and how you listened to your body and you didn't take no for an answer and you sought something that made more sense to you. The importance of that just can't be overstated. And I meet so many patients who, well, they told me not to worry, or my doctor told me to come back in 6 months, and I was getting worse and worse, but I was told not to worry. I was told it was something else. So congratulations for knowing better. And I hope that people listening to you tonight are, take heed and learn from the example that you set. So thank you for that.
Especially when you're young, I feel like a lot of young people don't, it's hard sometimes to speak up, but even if you're young, you know your body,
Maybe even especially if you're young, because listen, we all know that old docs sometimes don't have the best reputation for listening to young people or trusting them, or taking them as seriously as they ought to be taken. So doubly so because of your youth at the time. In terms of setting the stage for where Hodgkin lymphoma therapy is at now and how we got here, I would say that historically, like back in the 80s, 90s, the 2000s, to do clinical trials to try to make Hodgkin lymphoma better was all about intensification. So we heard Dr. Siegel, we heard Sam talk about de-intensification. Back then, it was all about intensification. How can I ratchet the treatment up to make it even stronger, even more toxic, but even stronger against the lymphoma? And we were sort of climbing that mountain of pushing to see just how much chemo we should cram into someone's gullet in pursuit of a cure. Because all we had was chemo, so what you want to do was more. We've really come over the other side of the mountain now, and we're in a very different place as a discipline, lymphoma experts in the field. And we've moved away from intensification, and now we're into de-intensification, personalization, and leveraging treatments other than chemotherapy as we try to help both maximize the chances of cure and minimize the short and long-term risks of our treatment. And we've gone away from uniformly using this ABVD cocktail, which remains a very good treatment and a very commonly used treatment. And now we're using more often other adjunctive treatments like a medicine called brentuximab vedotin, or Adcetris as its trade name. We'll talk more about that this evening, in lieu of the bleomycin that you heard both Chelsea and Sam talk about potentially injuring their lungs, leading to cough or shortness of breath. So we're finding ways to cure more people and at the same time cause less harm along the way. And that's really where the future of Hodgkin lymphoma is going to take us. And we'll talk about that this evening as well, as we try to even make more progress on this mission towards more effective and less toxic treatment.
Yeah, I love that that's the trend and that we can continue going down that path. So we will be talking about, to your point, some of these newer promising treatments and a new direction. But first, can you give us a little bit more about that standard first-line treatment for Hodgkin lymphoma?
Sure. So when we as oncologists meet a patient for the first time diagnosed with Hodgkin lymphoma and we work through their treatment choices, it's important to understand that there are choices there. But we think through those choices together with our patients and their families, sort of splitting people into different categories as we understand the risk of their disease and the options that are presented because of that. And one first sort of way to bucket people, to try to put people into categories to help think through their choices together, is based on stage. And we talk about Hodgkin lymphoma early stage and Hodgkin lymphoma advanced stage. And people will often ask, what's my numerical stage? It's stage 1, stage 2, stage 3, stage 4. We heard from Sam, I think that it was that sometimes it's not even clear to us as oncologists exactly what the stage is. Is it a stage 2E or is it a stage 4? So the staging exercise, which sometimes feels very black and white, can have shades of gray. But we do our best to try to put people into risk categories informed by their stage, and then think through the treatments that we know are best for that stage of illness. For early stage Hodgkin lymphoma, the standard of care remains, for the vast majority of people, ABVD. It's been around longer than I've been a doctor, and I used to have hair when I was using ABVD, so you know it's an oldie, but a goodie. And it still will cure the vast majority of patients. And sometimes we think about radiation therapy as part of that treatment, sometimes not. But ABVD for early stage Hodgkin lymphoma remains the standard of care. For advanced stage Hodgkin lymphoma, we've moved away from ABVD for most patients. And that's on the basis of really powerful clinical research that was conducted comparing ABVD to a program where the bleomycin was swapped out in lieu of this newer immunotherapy called brentuximab vedotin, which is a type of drug called an antibody drug conjugate. An antibody being a protein that binds onto the surface of a cell, and then stapled to that is a toxin. So this conglomerate thing attaches onto the Hodgkin cell absorbs it, and then the toxin is released inside the cell, kind of like a Trojan horse sneaking into the city and then releasing the soldiers inside. And it turned out that this newer program where bleomycin was swapped out for brentuximab, so BVAVD instead of ABVD, these initials are awful. It turns out that the newer treatment program not only got more people into remission and kept them in remission longer, but we now know that it actually leads to a higher cure rate and people living longer and everything good that we want to do as doctors for our patients. And because of this important research, we really now do use this brentuximab plus AVD program as our sort of traditional standard of care treatment for patients with advanced stage lymphoma in pursuit of cure.
Thank you for laying all that out. It's really interesting. You mentioned radiation therapy as well. And that has been its own sort of beast, if you will, in the conversations, a lot of considerations about when you're talking about long-term side effects and, where the mass is and you're radiating it. So what role do you think radiation therapy, what has it been playing? What role has it been playing? And what are your thoughts about whether it should still be used and in what situation?
It's a great question. And you're right, it is sort of its own beast. In the olden days, back even in like the 80s and early 90s, almost everybody with early stage Hodgkin lymphoma got radiation treatment as part of their care. And we knew then, and we know now, that it will cure a few more patients to use radiation therapy than not. But that slight improvement in cure rate never translated to people living longer because it's a trade-off. Yeah, we maybe do a little bit better with the Hodgkin lymphoma in some situations, but you're then paying a steep price. oftentimes in terms of long-term effects and late effects and risks of health problems later in life. And that can include anything from the radiation therapy putting patients at a higher risk for other cancers later in their life, particularly younger women who need radiation therapy to the chest. If that radiation touches the chest wall and touches breast tissue, particularly for women under the age of 35 or especially under 30, it really does heighten the risk of breast cancer later in life. Also, other stuff in your chest. Your heart is in there, it turns out, and the heart doesn't like radiation therapy much more than the rest of you. And we know that radiation therapy to the heart can lead to a higher risk of heart disease later in life. So there's all these consequences of the decisions that we make together in pursuit of our cure. And because we know so well about these late effects of radiation therapy, increasingly we try to be ultra choosy with who we use radiation therapy for. And we really restrict its use for what we think we really need it to get a cure. For many patients, for most patients even with Hodgkin lymphoma, we can cure them just fine without needing to use radiation therapy and without needing to put people at risk for health problems later in life because of that treatment. So we really restrict radiation therapy increasingly to use it if you need to. It's a great treatment. It can be life-saving when you need it, but don't use it willy-nilly.
Great. Thank you for providing that context and that color. So Chelsea, we're talking about side effects, short-term, long-term, late-term. You had mentioned in your introduction about the bleomycin, and you had experienced the toxicity, the side effects, and we've gotten lots of patient questions about it. And so with that the bleomycin, can you talk to us about what that reaction was and then what you did yourself about it?
Yeah, so after I think it was my 5th chemo, I think it was right before the new year, I remember it. I got the chemo like I had, 4 other times, but I went home and I spiked a really high fever all of a sudden. And, as a cancer patient, if it's like 100.4 or 3, you have to go. So mine was like 102, and my husband's like, we're getting in the car. And I was very lethargic and just not feeling well. So we ended up in the ER and they told me I was septic. And so of course my mom heard that as well. Like she was watching my daughter and just, freaking out because it's not good when you're septic. And they actually put me in the ICU, and I was in the ICU for at least 2 days. And the symptoms I had kind of dissipated after a few hours. I was feeling better, not 100%, but they started giving me antibiotics around the clock. And I had a feeling that it was something to do with the bleomycin, because I've researched what can happen with bleomycin because I have asthma, and that was something I had to consider going into the treatments. Everything I was seeing was adding up to it being toxicity, but there was nobody at that hospital who really treated cancer patients. Like they came in and out, but they weren't there all the time. And it took about 4 days for my oncologist to actually come see me. And in that time, I pretty much diagnosed myself with bleomycin toxicity. I also stopped accepting the antibiotics because it wasn't an infection. It was a reaction to this drug, and ended up being that, yes, it was toxicity. It was confirmed later on. And I also had a pulmonary function test, and I think I had like a 30-point drop or something. And I am happy to report that I have regained a lot of my pulmonary function now, this many years out. So I know a lot of people, that's something scary when you do go through this. But yeah, and that, the doctor was speaking of, you need to advocate for yourself, especially when you're in a situation where your cancer probably better than the people that are there immediately. Like it's not your regular care team. This was just a local hospital and they had never seen this before. And so I had to speak up for myself, and it was hard, but I did it.
I really appreciate that you're spelling that out, that Dr. Matazar talked about it earlier too. I know Sam's a huge proponent of that as well. And we'll talk about seeing a specialist at the end of the program too. But Chelsea, just to double click on that for a second, you said it was hard. And I think we've all experienced that as patients, where you want to advocate for yourself. You hear it from other people. It can be a little bit difficult to just speak up because you're like, well, I don't know, they're supposed to be they're leaving. So do you have any other tips, I guess, for people who are on the fence about it, who aren't sure if they're supposed to speak up?
Yeah, I mean, to be honest with you, I was not a great advocate for myself when I first got sick. I mean, the oncologist I ended up with was the one that was just walking by when I was in the ER initially, and I thought it was fate. It wasn't. He immediately upon meeting him in his office, he told me it was a good cancer, all sorts of things. In my case, I was like a unicorn of the Hodgkins, nothing went how it was supposed to go. It wasn't good at all. And sometimes I was quiet about it, or I didn't know what to do because he was very like, I always looked things up, and he would call me Dr. Google, but not in a nice way. And so I was scared to bring up a lot of things. So I would tell you, if you are a young person and you are scared, or even a young woman, sometimes it's when you're a girl and you have a male doctor, sometimes it can be intimidating. Bring your family with you or somebody else you trust and have them speak up for you if you are scared to do it. I know a lot of people do that, and it's helpful because when you're inside of that room listening, your mind kind of goes fuzzy and you don't even know what's going on half the time. So it can be the difference between having a good result or ending up, pretty much needing a transplant like I did. I truly believe that if I would have been a better advocate, that I might have not needed one.
Thank you for going into all that. And I completely can attest to the blinking out in the doctor's office and not hearing the same thing that like my family heard or whatever. So I appreciate that tip of, hey, bring people in if you can. Thank you, Chelsea. So excellent. Click that. We're going to bring in a patient question here as we shift into talking about combination therapy for frontline. Matthew asking, how successful have immunotherapy trials been in regards to Hodgkin lymphoma? And that is, of course, a huge part of our conversation tonight. And I know we'll talk a little bit more. We're getting a couple questions into live about some of these things. So Dr. Matazar, we'll talk about the specific trials, but can you explain first, what is the idea behind the combination drug approaches? And again, for whom would this benefit, hopefully?
So we've been talking so far. We talked about ABVD. We've talked about the progress that we've made beyond that with the swapping out of this brentuximab vedotin medicine instead of the old-fashioned bleomycin. Matthew asked this question about immunotherapy is a really valuable one, because indeed, this idea of immunotherapy has really been a revolution in a lot of different forms of cancer. But really nowhere has it been more impactful than in Hodgkin lymphoma, period, full stop, new paragraph. When we talk about immunotherapy in Hodgkin lymphoma, what we're generally speaking about is a class of medicines that have this nickname called checkpoint inhibitors, which is meaningless in and of itself, but I'll try to at least describe what these medicines do and how they do it. One of the way that these Hodgkin cells that I described initially, these grains of sand, one of the ways that these cells survive in our body is that they are able to effectively shield themselves from our normal healthy immune system cells. And they put up these barricades and these ways of shielding themselves or hiding or preventing our immune system from doing the trash. Checkpoint inhibitors, and there's two of these that are approved for Hodgkin lymphoma, which are very similar medicines, truthfully. One called nivolumab, and one called pembrolizumab. And again, these names are awful, so I'll call them Nivo and Pembro for short. These medicines are able to strip those shields, those barricades off of the Hodgkin lymphoma cells and allow your immune system to see what it was otherwise blind to. So when you're giving a patient a medicine like, the treatment itself does nothing to the cancer cell. It does not kill a single cell all by itself. What it does is it re-enables your own body's immune system to do the work for us. And it's a game changer. When we use these medicines just as a single medicine all by itself, not combined with chemo, not nothing, just all by its lonesome self, and use it as a treatment for a patient who's been failed by many different prior chemotherapies, brentuximab, all the other stuff that we traditionally do, they're able to put people into remission more than half the time all by themselves. And not just remission, but they're able to actually cure some patients. Cure means, despite chemotherapy having failed again and again and again, this medicine is able to eradicate the lymphoma, goes away, never comes back happily ever after the end. And that's amazingly powerful to be able to say. And it's an amazingly powerful treatment modality for patients with Hodgkin lymphoma. So that's where immunotherapy sort of started in Hodgkin lymphoma. And the more we learn about how good these medicines work, the more we want to use them for more patients to try to help cure more people. So it went from being a last-ditch effort after everything else has failed to being part of the treatment when it comes back after treatments like ABVD. And using it in that situation was able to help more patients. And now we're seeing the initial results of our first trials of using it as part of first treatment. So instead of ABVD or brentuximab plus AVD, we're now starting to see first results come out from incorporating these in combination with chemotherapy like AVD, but instead of combining that with bleo or with brentuximab, now we're combining it with nivo or pembro, these newer checkpoint inhibitors, and starting to see early results that are very promising.
Wonderful. Thank you for sharing that. I think that I would like to ask the question just before we move on a little bit too much too. We got one about how common. So let's rewind it a little bit. There's actually two questions that come in kind of related to this sort of section. One is about brentuximab and AVD, and the question of maybe how much is it being used? I mean, I know you practice where you practice, but is there a feeling of how much it is standard of care, or is it really it just varies depending on the hospital system or the healthcare provider versus going to ABVD first line?
So, it's a little bit hard, right? Everybody's situation is a little bit different. There are standards of care, which means that all things being equal, sort of a one-size-fits-all approach. Medicine's never that clean or that easy. And there's times where ABVD would be a standard for early stage disease, but we have to use brentuximab instead of bleo. There's people with advanced stage disease who we say, even though BV-AVD would be the standard, I still want to use ABVD for this individual patient. And this happens because doctors listen to our patients and we take into account their personal priorities, their preferences, their individual risk profile, because medicines like brentuximab and bleomycin and even nivo and pembro, all these medicines, sorry for my dog barking, all these medicines have their own pros and cons and their own sort of risks and their own rewards. So a treatment program really is best when it's personalized and it's done in the context of a doctor and a patient having meaningful and valuable conversations about what matters to that person. Is it just cure regardless of side effects? Is it being able to play the guitar and run? What is it about the treatment that we need to take into account as we map a path towards cure?
Great, wonderful. Thank you for that. Really quickly, before we shift into the relapse refractory part of our discussion, any idea of when we could see the FDA approval of this sort of movement to the checkpoint inhibitors in frontline?
Certainly not anytime super soon. The first results that we had were read out at major conferences over these last months. This is still very early data. And listen, when it comes to Hodgkin lymphoma, us doctors were very conservative. We don't want to mess this up because we know that the stakes are high and we know that many people will be cured with traditional treatments. So we don't want to change gears until we're really confident that we're not hurting people in the process, right? So the initial safety readout of this combination using the checkpoint inhibitors in first treatment looked, I would say, better than any of us expected. A lot less of the immune-related side effects that we're accustomed to seeing when using these immunotherapies. And they do have their own immune-related side effects. There's no free lunch. So we want to see those data mature, as we say. We want to see how people do over time and make sure that there's no safety signals, no dangerous signals about increased late effects or late side effects happening as we gain more experience with this treatment approach.
Great.
Long story short, we don't want to change any time immediately soon. And we're probably looking a couple of years down.
Okay, that's good to know. We do need to shift into the relapse refractory section, and we got caught up a lot in the details. Wish we could do the program for 2 more hours, but we can't. So Dr. Manazar, let's talk about the treatments that have been standard of care for relapse refractory Hodgkin lymphoma patients, and how is it changing?
So again, you're going to hear themes from me this evening, right? Which is that we've moved away from chemo to trying to use newer medicines. So historically, When chemo failed, how about some more chemo? And we would use these other chemotherapy programs that use different chemotherapy medicines than the first cocktail. And the most commonly used in America historically was a program called ICE. So it's ICE, different than ABVD because they're different medicines, but still chemo. We've really moved away from ICE being the standard of care, or certainly not the only standard of care. And we're using more of those other medicines, brentuximab, the checkpoint inhibitors. You can use one of them all by itself. You can use them in combination. It's informed, of course, by what we did the first time. So if patients get brentuximab as part of their first treatment, we're not going to rush into doing it a second time. And we'll probably want to do something a little different. So maybe we would use checkpoint inhibitors there alone, or combined with some milder chemotherapy programs. This is sort of the art of medicine, right? Trying to pick amongst a number of very effective choices, chemotherapy, brentuximab, checkpoint inhibitors, and how do we leverage those medicines and how do we combine them to achieve our patients' goals? Always with this view of maximizing the good and minimizing the bad.
Wonderful. Thank you so much, Dr. Matazar. Sam, want to go to you because, you know, in your story, in your experience, you relapsed just a month after finishing your first line treatment. Can't even imagine what a gut punch that was to go through all that and then find out that news. Can you just give a quick summary of, you know, what was that conversation like about where you were going to go next?
Yeah, absolutely. And gut punch is a really great way to put it because it was. But I finished the 6 months of, you know, ABVD that then went down to AVD. And gosh, I felt, despite a scan saying that I had no evidence of disease, I felt pretty awful. And at that point, I wasn't sure, like, am I just feeling awful because this is just what a body feels like after you've had 6 months of this poison? I'm not sure. But something in my gut was telling me like something isn't right yet. But my skin was clean. So just kind of focused on recovery for a little bit. And then within a month, I really started having symptoms that were eerily reminiscent of my initial symptoms. So like just a wheeze only in the left upper part of my chest and a little pea-sized lump. And so that time around, I was like, okay, I think I'm pretty clear what's happening here. Got a scan, led to some biopsies and a diagnosis of a relapse. And the whole while I'm preparing myself like, oh my gosh, I'm going to have to go through ICE. Like I'm already researching on Google, like the next, you know, treatment regimen that I'm going to have to go through. And I'm thinking for sure I'm going to have to go through something called ICE or DHAP or one of these other regimens that have been used longer term for relapse refractory Hodgkin's or salvage therapy. And so then when the relapse was confirmed and my doctor said, you know, there's this drug now, it's this targeted therapy called brentuximab, and we're going to try, like, would you be open to trying that alone for a couple months and then repeating a PET scan to see where we're at instead of just doing the ICE? And the kind of decision making there was that there was a pretty decent chance that if the brentuximab didn't work to get me into remission before transplant, that I would then have to go on to get ICE, multi-drug, kind of more traditional chemo. But that was a chance I was willing to take at the time because I felt so beaten up by having to get, you know, all those months of traditional cytotoxic chemotherapy and just all the side effects. And so that decision made sense to me in my life at that time. Whereas maybe other people may have been, no, I want to hit it hard and do that right away. For me, I was like, I'm going to take the least amount of poison possible to get me into remission before transplant. And it worked. I got a strong remission before my transplant. And then I went on to get the bone marrow transplant. And then I took brentuximab. I just finished 2 months ago for almost a year of post-transplant consolidation treatment. So yeah. But it was like, for me, it was like real time because even 6 months, a year before, had that exact same clinical scenario happened, based on the science, that may not have been an option. But because those studies were just coming through and the data, my doctor said, you know, this is kind of becoming a thing now based on the research. And this seems like it might really fit you based on how, you know, bad you're feeling. And so that was perfect for me. I was so grateful. But I think, yeah, Chelsea will tell us there's other experiences, you know, so.
Yeah, no, and I appreciate that. And it just that the timing matters, right? To your point, it just had happened. You had also mentioned in terms of like the reactions or side effects, you worked with your doctor to manage them. Can you share anything that was helpful there?
Yeah, I mean, I have a lot of side effects. I had a lot of nausea, vomiting, and yet like paradoxically gained a ton of weight during AVD from all the steroids, just kind of blew up. And was developing a lot of problems from that. Glucose, liver enzymes were increasing, inflammation in various organs. And I think actually in hindsight, that was also making neuropathy really bad at the time, because once my glucose got better and I lost the weight, my pain and my nerves got better too, despite the fact that I was getting more medicine that theoretically should have been impacting the nerves. So all the systems can kind of have an impact, and taking care of the whole body can be really important. And so, yeah, I talked to my doctor about diet, lifestyle, and supportive therapy, and what are some complementary therapies that I could try while I'm getting my traditional medicines to support my mitigating that. And I also took a lot of medicine at the time. I needed pain medicine. I needed nausea medicine. I needed all the tools in the toolbox to cope with living day to day, because it was just really hard. And I had a lot of the medicines for me cause a lot of mood and neuropsychiatric side effects. So I had problems thinking. I had problems at some points like driving or following a list of simple items, and that was really tough for me. That was a really far fall in terms of functioning, going from doctor to like now I'm having trouble shopping a grocery list of 5 items. And so that was pretty devastating. So when I found out that I could do brentuximab as therapy leading up to transplant, that gave me huge quality of life back, because as those other drugs cleared out and my body healed, I could think again, and I started feeling myself in here again, and like I'm not gone, I'm still there, and that mattered so much to me. It was a huge gift.
Thank you. I really appreciate you really bringing that to life, because yeah, sometimes we feel lost in that sort of fog, and how important it is to just get any semblance of that quality of life back of ourselves. And I think your story shares that so powerfully. So thank you, Sam. And we got a great question. We wanted to get to what was Stuart's asking, please explain transplant. So before we get to Chelsea, who's going to give another sort of, comparison of an experience before her transplant, Dr. Matazar, again, that challenge of less jargon. Can you explain the transplant in this context?
Totally. So the first thing to say is that there's 2 types of transplant. And what we're talking about so far is a treatment that is the full name of which is called autologous, or from yourself stem cell transplant. And to call it a transplant is actually wrong. There's no transplantation going on. It's just a word that we use. What this treatment is that you're hearing from Chelsea and Sam is basically just a trick. And it's a way of letting us give a round of super strong treatment. When you give a regular strength treatment like ABVD or the ice that you heard mentioned, we give those treatments and then you let people recover. Sometimes if the chemo's stronger, you might need to give a little bit of medicine to boost the recovery along. Here, we're talking about a treatment, a single course of treatment, usually 6 days, that is so strong that if I just gave it to my patient and gave them a hug and said, I'll see you later, I wouldn't see you later. It's too strong. And we need a very powerful antidote for such powerful treatment. And the antidote that we use is actually a person's own stem cells, these special Adam and Eve progenitor cells that live in our bodies and let us heal. And a process is undertaken where we actually filter the blood ahead of time with a process like a little mini dialysis, where we filter out a few of those special stem cells. We put them in the freezer next to the chicken parm, and then we give people the 6 days of chemotherapy, and then we thaw out those cells and give them back as an antidote. That course of the 6 days of treatment, and then the stem cell reinfusion as a little mini transfusion as the antidote, that program is what we here are calling a transplant. That's different than an allogeneic or donor stem cell transplant, where there really is transplantation going on, where your immune system is being put to sleep and a new immune system from a sibling or a stranger is being put into your body to give you a new immune system. And then we task that new immune system with attacking your cancer for us. that's a very different ball of yarn, and really not what we've been talking about this evening.
Wonderful. Thank you, Dr. Matazar. We did get a patient question from Caitlin M. For relapsed refractory patients, are there other options aside from chemo to get into remission before stem cell transplant? And, Sam did give an example of what she went through instead of going into that very harsh ICE, regimen, which now we can actually go to Chelsea about with your experience, because you also got a transplant. You went through immunotherapy. It was offered to you. This is all in the last couple, right? It was very recent. You did go through immunotherapy, but unlike Sam, it didn't respond. And that your PET scan after 3 cycles of that, it showed disease progression. And again, gut punch, I can't imagine what that was like. It would be great to understand more about your experience there in terms of, the conversation you were having with your doctor ahead of the transplant. Are there questions you wish you'd asked your doctor that maybe some of our audience might be able to take away tonight?
So I relapsed in 2019. It was a later part of 2019, and I switched over to Mayo Clinic in Jacksonville, Florida for my care. And I had been researching, through the relapse refractory Hodgkin's groups out there on Facebook. I saw that there was nivolumab, brentuximab, all of those things, and they were a lot less harsh. So I asked about it when I went there, and it was kind of a newer thing at that time. And my oncologist said, yeah, we can give it a try. It's had really good results. And, like Sam spoke to, the side effects for ICE and the side effects for brentuximab is a night and day difference. So I don't think like anybody wouldn't try the less harsh one leading up to transplant. So I did. And I had 3 of those treatments, had a scan, and my cancer progressed. And my oncologist was honestly shocked as well that it didn't respond whatsoever. And that made me actually ineligible for maintenance, like what Sam had. I'm not eligible for that. I didn't get any. But so we switched to ICE, and ICE was the first chemo where I had to be inpatient. I was inpatient for 3 days every time, and it was intense. Like when your hair falls out on ABVD, for the most part, it's like slowly coming out. Well, with ICE, pretty much 2 weeks to the time I had it was like just clumps of hair coming out, and I was very sick. It was very, very harsh chemo. And I think just really having open discussions with your oncologist, like if you do find other studies or other treatments, they should be open to answering your questions about it and not being dismissive, even if it's not an option for you. They should be able to explain to you why or why not. And definitely if you are a young person about to face a transplant, make sure that, or even if you're not, but if you're in childbearing age, please ask about fertility, because I am now in menopause at 33 years old. It was explained to me, I understood, and we didn't really have time to waste to get me to the transplant, but that's a conversation you should bring up not only when you're going into a transplant, but when you first get diagnosed with cancer.
Thank you, Chelsea. Yeah, those are very important questions. I was lucky to just have first line treatment and be okay, but I asked that question before my intensive chemotherapy. And so I think it's great whenever we're reminded, advocate for yourself depending on what you want, your life to look like. So Dr. Matazar, for relapse refractory patients, can you summarize sort of this combination of chemo and immunotherapy, and in the context of a transplant, hopefully what this might lead to?
Yeah. So the goal up until now has always been for patients who have their disease come back despite good first treatment is to get their disease into remission, meaning make their disease disappear on our scans and have a PET scan look normal, and then to take them into this round of high dose therapy, this auto transplant, in an attempt to maximize the chances of cure. We're now starting to see our first forays into, can we cure people reliably and consistently without a transplant by leveraging these immunotherapies, either alone or in combination with chemotherapy. This remains a clinical trial type question. This is not a DIY thing, but this is my hope for the future, is that we'll be able to use these treatments, particularly immunotherapies, to really limit our need to take people through the rigors of high dose chemotherapy, cure more people, and cause fewer problems and symptoms.
Great. There's a question from our audience, from David S., we can't go into specifics about each person's case, right? But I think a good general question coming out of it has something to do with knowing, especially when you get more options, that's great in any area, but then maybe sequencing, or where do we go first if something happens? And so, what happens, I guess, if these studies are happening and it's limited to what's approved, and if you can get into a clinical trial, but let's just say that it's on the table. If the ABVD doesn't work, that there's a relapse refractory situation, maybe there's some radiation that's been involved, some other things. And then you have these studies about, brentuximab or nivolumab or pembro, maybe alone or in combination. Like, how are doctors having that conversation about what is the right thing to do next, or what is the most promising course of option next?
Yeah, it's really hard, right? This is the art, standing next to the science. And my art is not Chelsea's art, but there is some artistry to what we try to do, and to try to figure out the right lid for each pot, and how do you help a patient navigate their course of their illness. There is no one size fits all anymore. It used to be ice baby, like it's all we did, and it worked good, and it was awful. But now we have a range of choices, and you have to sit with a patient and think through, how much disease is there that I'm trying to shrink away? How quickly is it growing? How do you feel? How sick is it making you? How quick do we need to get you better? What was your first treatment? How well did it work? How badly did it not work? And take all of these factors and try to cram it into your doctorly, brain, and try to spit out some reasonable recommendations. Sometimes you're going to be as gentle as brentuximab all by itself. Sometimes you'll want to give more chemo. Sometimes you'll want to give checkpoint inhibitors alone or with BV. Sometimes you want to do checkpoint inhibitors plus chemo. These are all reasonable courses. Ideally, what you're doing as a doctor is working with your patient as a person, as an individual, and charting a course that makes sense for them, for their illness, and for their life.
Yeah, it's a really thoughtful response. And I think, are some of the considerations, I heard you say it's the treatments you had before, how successful they were, what's already been done. What about things like age or comorbidities or those kinds of factors?
Absolutely. And, we try not to be ageist, but truthfully, taking care of a 30-year-old is different than taking care of a 90-year-old. And to not recognize that would be silly. That being said, it's always a matter of individualization, understanding an individual person's goals, their preferences, what risks they're willing to take, what matters to them, and then try to figure out the best treatment for that person, given everything you know about them, about their value system, and about their goals of care.
Wonderful. I wish every doctor thought like you. That's great, Dr. Mazur. Thank you. Just a couple more, quick topics here, but one that's very important, we've talked about it a little bit, is the long-term or late-term side effects. There's a patient question from Ariadne J, also about this. What is known about long-term post-treatment side effects? I think all three of you could probably answer some of this. Let's go to Sam first. About maybe you and Chelsea can both talk about what you've experienced. You can laundry list, you can talk about what has been the most impactful and anything that's been helpful, hopefully, to get through some of these things. So Sam, we'll start with you.
I love this question because now I can plug survivorship, which is basically my newfound life passion as a patient doctor. And cancer survivorship, even though a lot of people don't necessarily identify with the word survivor, it's an important thing to kind of keep your finger on the pulse of, because survivorship applies to this area in medicine that's changing, that's evolving. I think ultimately it will be a board certified specialty, but that's a little bit ways down. But it's anybody living after a cancer diagnosis, and that could be during treatment if you're on long-term treatment, that could be after your treatment's over. But there are a lot of ways that cancer treatment, the cancer experience, even if the treatment goes perfectly, but just the experience of getting diagnosed and questioning your life when you're in your 30s and having your fertility changed. And there are all these things that get impacted once you hear that big C word. And survivorship is kind of this evolving area in medicine that kind of is trying to address all of that. For me, there was a lot. There was identity. There was like this existential crisis, death and dying, and making sense of all of that. A lot of cognitive issues. The the steroids and the other medicine that I had to take impacted my thinking and my emotions, and I'm usually a pretty balanced, even person, and so that was a very hard roller coaster. There's some cardiac stuff for some people, adriamycin, which is part of the initial treatment. I think that we really need to be thinking about, we're giving people this medicine that's toxic to the heart in their 20s, 30s, 40s. We need to be talking about really intensive lifestyle interventions like healthy diet, cardiovascular exercise, a lot of that stuff. So I think an overall kind of program that focuses on wellness is hugely important with managing long-term side effects. And integrative medicine, I'm actually doing the integrative medicine fellowship right now, which is very exciting, trying to kind of unify everything that I learned in medical school with everything I needed as a patient to get better from cancer and cancer treatment, and hoping to offer that to other people. But those are some kind of practitioners that you could consider going to, or things looking up. Just make sure that you communicate everything you're trying and doing with all of the people who are in charge of your care, including yourself. You're an important part of that conversation. But yeah, cancer survivorship is super important for managing long-term side effects. Yeah.
Thank you, Sam. By the way, you said integrative, and I saw Dr. Mattis go, yeah, or something. So that was an emphatic, supportive, I think, gesture from him. Chelsea, how about you? What for you were the sort of long-term side effects? I know for you, you talked already about the going into menopause as a consideration, for instance.
Yeah, I think that the main thing I struggle with that is the most apparent in my everyday life is probably the cognitive side effects from just all the different treatments. And I honestly think from the extreme stress that I was under for so long, I was so I was on this job at an insurance company, and I had to balance things with legal documents. And I just know that if I were to go back to that job, I would not be able to do it now. And that's taking me a long time to see that that's okay, and that I still am me, just have to kind of work with things differently. So physically wise, I have, fatigue a lot of times, joint pain. I often joke that inside I'm 80 years old, but on the outside I'm in my 30s. So it feels like that. And Sam mentioned, there's a lot of identity crisis that you have as a cancer patient. You're who am I now? What happened to the old me? What can I do? And I really want to encourage people to seek community, because I think that once you hear from people that, they feel the same way you do, even just hearing from Sam, I'm sure some of you are oh, other people feel like that. That's definitely what inspired me to start making art and connecting with others. And it can truly make a difference in your long-term just mental health in survivorship.
Yeah, thank you so much, Chelsea. And I think you capture a lot of that in your artwork. So be sure to check out Oh, You're So Tough. Dr. Matazar, with the newer therapies that are either just approved or in the pipeline, are we addressing some of these long-term, late-term side effects that hopefully people can avoid even years later after treatment ends?
We are. I think that number one is to say that a lot of the drive to develop these newer treatments has been informed by our understanding of late effects and of cancer survivorship, and understanding well the risks that survivors of Hodgkin lymphoma treated with more traditional treatments go on to face. So that's been a lot of the driving force behind these efforts to improve our treatments. And yet we still need to follow with these newer treatments to watch for the possibility of late effects. We don't believe that they're going to cause as many or as severe, but part of the work of survivorship is learning from our survivors and walking that path with them as we see how their lives unfold over the years and decades to come. The number one thing that I would encourage survivors to do is to work with your care teams on developing what's called a survivorship care plan, which is a document. It could be a paper document, it could be a digital document, but it should be something that lives with you, that says what your diagnosis was, what your treatments were, and what our understanding is of what you can be doing to safeguard your health in the years to come. And that's informed by understanding what the possible long-term consequences of the treatments that you personally received, and how we think as doctors you're best served by taking care of yourself, and what we can do as doctors to prevent or reduce the risk of those problems as you go on to live your lives.
Wonderful. And that's a great tip. And I think it's great that the trend of more focus on survivorship during treatment, after treatment, is going to do wonders for so many people. Moving now to shared treatment decision-making, which we hope for those of you watching now live are you're going to really take away from this. It's important, right? We're all wanting to be more empowered in our care, to be able to ask doctors the questions, to feel that we can, to ask ones that'll be, impactful. Dr. Matazar, you talked about the right treatment for each patient depends on all these different things: age, health, transplant eligibility, goals of therapy. But how can a patient find out what are the best treatment options for them, and in what order? I mean, if you could summarize from the doctor perspective of what that conversation could really be to elicit the best response for patients and their family members.
Yeah. And I was really disheartened, Chelsea, to hear your story of your doctor disparagingly calling you Dr. Google. Nobody should have to deal with this stuff anymore. We've got to be better than that.
I'm like, thank goodness I was, because if I wasn't, I would.
No shit, right?
Exactly.
So number one is everybody should feel empowered to come into a conversation with a doctor as an equal partner in this process. I tell my patients, this is about you. It's not about me. I got no ego in this. And it's your mountain you're climbing. I'm not climbing the mountain. I'm the Sherpa. I'm dragging your bags alongside you, but this is your climb. And I'm here to help. So if you as patients, as caregivers, aren't feeling valued and heard, then you may not have found a right fit for you in terms of your care team. Everybody should always feel free to be getting a second opinion. And I think that not enough people take advantage of this sometimes. They don't want to insult their doctor. I don't want to be that guy or that gal, and I don't want to be a pain in the ass. Be a pain in the ass. I like nothing more than when my patients are pains in the ass and they come to me with lots of questions. It means they're doing their homework and they're really invested and they want to learn and they want to take advantage of whatever I've got up in my brain. I love nothing more, and any doctor should love nothing more than a patient who's all in on partnering with me on making this thing work. So be vocal, do your research if you want to. You don't have to, you shouldn't have to, but if you want to, and if it's something that you value, then that should be celebrated by your care team and never put down.
Wow, that's amazing. There is going to be a part where you all three are going to share final takeaways. I think Dr. Matazar's is be a pain in the ass, which I love. I think that should be a bumper sticker. Just go in the doctor's office, and that's the number one goal. And everyone wins. But on the serious side, so Dr. Matazar, there have been questions all night just about also these different situations, and it's clear that people, especially relapse refractory, and if people are experiencing multiple relapses, it's hard sometimes to find maybe one answer from one doctor. They seek, different opinions or getting different responses. And it's a very personal discussion to be had. But this does beg the question of, is there, a right time to find a Hodgkin lymphoma specialist? I mean, is there, when should that happen? How can you have that conversation? Just anything here, I think, would be helpful for some of our audience.
Yeah. It's tough, right? Because it is very personal. My general philosophy is that people deserve to have expertise in their corner. And I also recognize that people want to receive care close to home, and they should be able to receive good care close to home. In an ideal world, everybody would have an oncologist who lives close to them, and everybody would have access to an expert to support the decision-making and to support the care journey. Sometimes that would be the same person. If you live near an expert, perfect. If you don't have an expert in your neck of the woods and then you should be having the opportunity to seek out that expert as a consultant and as a backup. And then that doctor would work collaboratively with your local oncologist as a team to make sure that they're doing everything to the best of their ability. And then you have the expert as sort of on standby in case things go sideways. In my mind, that's the ideal. And I would encourage my patients, if they're not comfortable with what they're hearing, even from me as an expert, go see somebody else. Hear from another set of lips, get a fresh perspective. Maybe there'll be a better fit in terms of that critical doctor-patient relationship. Any doctor who doesn't want you to get a second opinion doesn't deserve to be your first opinion. Find the care that feels right to you. Trust your gut. And the importance of the doctor-patient relationship is too great. It's too critical in a relationship to settle for anything less than the best.
Amen. And I mean, I saw Sam grasp her heart or something, you clutch her heart when you said that, because I think it's so resonant and it's powerful to hear from someone like you too, Dr. Matazar. So recap, if the doctor doesn't support you getting a second opinion, they're not worthy of being your first opinion, something like that, right? I really love that. Another bumper sticker. I guess, this is a good time to sort of wrap, maybe with that sort of final message, from each of you. Dr. Matazar, if there's anything else you want to add to all the gems you've already given us tonight, what would you really want people to take away tonight from this discussion, from your perspective?
Yeah, I would just bring it back to the patient story. I mean, what you're doing tonight, what we're doing together tonight, is kind of where modern medicine should be. We should be building community. We should be sharing experiences and sharing our stories and supporting one another. Every patient's journey is unique, and yet we don't walk these paths alone. And if you can find yourselves ways to build community and to be supported by various communities, it makes the journey a little bit less painful.
Thank you so much, Dr. Matazar. Chelsea, anything you'd like to add here?
Yeah, I think, he said it really well that, when I went to my second doctor, I felt just a comfort and a care that I hadn't gotten before. And so, making sure that you are having a good relationship with your doctor, and then a sense of community is very important, because a lot of society puts a little bit of an expectation on our shoulders to always be brave, positive, strong warriors, and not everyone feels that way. And I just want you to know that's okay. And it's okay to authentically be yourself and talk about the hard parts of cancer, not all just the smiling, ringing the bells, all of that, because there's a lot more to cancer than that. And I think it's okay for you to feel the way that you feel, however that is.
That was powerful too. Thank you, Chelsea. And Sam?
Yeah. I think that a couple of key things that I've learned are having lots of questions doesn't make you anxious. So it's okay to have lots of questions and concerns and to look things up. That doesn't mean that you're an anxious person. And I think it's okay to really reject that label, because I think it means that you're just appropriately concerned about your life and the quality of your life. And I also think that some doctors may be more attuned to knowing to ask about what's really important to you in your life. Some people may be really busy, they may forget that kind of thing. So as the patients, it's up to us to tell our doctors what's really important to us. Running's really important to me. Playing guitar is really important to me. I love painting. All the things that we like doing. Share with your doctor what's really important to you. Not only will I think it help them kind of just enjoy their day a little bit more, to know you as a human being, but it will really help to inform the treatment decisions. And I think that there were times in my treatment and stories that I've heard from other patients in groups where it felt like to want anything more than not dying, I felt like I was made to feel like it was greedy to just want more than just not dying as a cancer patient. But I think we're beyond that now in medicine. I think we are in the era of personalization, of community, of individualized kind of care within the guidelines of all the new things that are being discovered. And it's not greedy to want to keep exercising to some degree, or keep doing your art or whatever defines quality of life for you. So yeah, it's tell your doctor what's important to you, reject the anxiety label, and my whole slogan that I'm trying to get going is let's shift the focus from mortality to vitality in cancer. I think vitality in cancer is huge, and it's so much more than just not dying. It's the living part.
And you both have exemplified that so much, and really grateful to have had you, Chelsea, Dr. Matazar, doing your work in research and helping patients and families holistically. Thank you for the work that all three of you are doing as advocates, really. Before we go, we want to leave people also with some resources that will also drop in a follow-up email from the LLS. There's support for teens and young adults. There's the LLS community, which is a forum. It has a scholarship for blood cancer survivors, so there's a financial aspect there. From Immerman Angels, again, just talking about how it specializes in its Mentor Angel support program. And then from the patient story, you know, we've got these programs, but also the stories that we do. And the newsletter that we have will let you know about all the upcoming events. The follow-up email from this program will have the video, the transcript, and links to all the resources, as well as questions we didn't get to tonight. We'll try to address in that follow-up email. So again, thank you, Dr. Matazar. Thank you, Sam, Dr. Sam Siegel. Thank you, Chelsea Gomez, also known as Oh, You're So Tough. When this box closes, remember a survey will pop up for everyone. And please, we'd love to hear from you. Once you complete it, it'll automatically enter you into that raffle for a $50 Amazon gift card, which I hopefully will be helpful for some folks. So thank you again for joining us all tonight, to our panelists and to those who joined us live. We hope to see you at our next program. Good night and take good care.